the 80-year-old with a very large atrium and a long-standing persistent AFib are the few patients that we don't do. Um, I think the patients that actually get left out of this more than anything else are the people that are newly paroxysmal or had just have a remote history of AFib. I think if we look at our data carefully, those are the patients that kind of get left out the most, and those are actually the patients that are the easiest to cure, frankly.
I agree.
I don't know if you would agree with that, Dr. Philpott, but those seems like to me those are the patients
Well,
that get left out.
yeah, Lauren and I were just laughing because we just went through some of the data today on the ones that coded in positive, and yeah, we didn't do them because they had, exactly what you're talking about. The one single bout of atrial fibrillation 3 years ago while they had another event, an asthmatic attack or whatever, and never had any atrial fibrillation since. Or the one who had like one brief run and then, that was like 3 years ago and never had another bit of it. And then you do her mitral and you talk yourself out of the maze procedure because it was just this one self-terminating event. And then the entire post-operative period, she's in atrial fibrillation and either running fast or running slow, and they're having the discussions about the pacemaker. And the entire time you're thinking, my God, why didn't I just do the maze procedure while I was in there? But it does make it very hard because you would like to have them meet into that definition. And those people, particularly the ones that have that single episode prior that's very brief and self-terminates and have never had another event, are really kind of hard to codify. Now, older patients, I wouldn't say that we stay away from people that have been in it for a long duration. We tend to be pretty aggressive about that. Their success rates are not as good, but they're still very good. The one element that does scare us off is the large left atrium. If it's 6.5 to 7, we'll probably think long and hard about not doing a maze in that patient.
The other situation where I think we struggle with whether to do a maze or not, and actually my last patient on this, his AFib was really bothersome to him. And when I say bothersome, meaning that he was very symptomatic in AFib, even though paroxysmal, and he was a redo CABG with an intact IMA. I think those cases, I think people shy away from. But there's other options that you can do in terms of doing a box lesion, in terms of opening the left atrium and just doing an intracardiac cryomaze. I took the time to dissect out his mammary in its full course and get around the left side of pulmonary veins. And yes, it was hard. And yes, it added an hour. But in him, I thought it was worth it. But there are other options. I think those are people that we tend to shy away from, the redos with the intact mammaries and the patients like Dr. Zias was describing, the long-standing persistence with the giant left atrium. Besides that, we tend to treat everyone. Katie, would you agree?
Yeah, I would agree. I have just two comments on that. One patient population I struggle a bit with is the patient we get in and there's adhesions that were unexpected, and I'm going to be doing a maze on them. And so if I can get to the left atrium and open it, in that case, I think it's worthwhile. But I may not go around the veins or go around the backside of the heart if there's a lot of adhesions. And my other question was for Dr. Philpott and Dr. Zias. Do you think there's any benefit in a patient that still has longstanding or persistent AFib in reducing their AFib burden, even if you can't get them back into sinus rhythm, by doing a maze procedure at the time of their surgery?
I can probably take that first. I think that sounds really good, but at least in our practice, it hasn't borne fruit. It seems that when they fail, they fail.
Okay.
It's not so much as a burden as much as they're just in AFib, and that's what we saw in the studies as well. Now, having said that, probably a key point out of this WebEx, so I hope everybody learns, is that if they fail, don't shut the book. Call your electrophysiologist, get them remapped and reablated. A lot of times they can take an initial failed maze or even a late failed maze and tune it up, and now all of a sudden it's a success.
I couldn't emphasize that anymore. In that, but this has been a process for us. It's been very difficult to get the EPs to take back post-maze patients. But what they usually find, and I can think of the last one that they did for me, when the EP told me, is it's a maze that I did on someone 6 years ago who recurred this year. He said, from an EP standpoint, you have to spend a lot of time mapping and figure out exactly where the break is, because it's a box. It's not like Convergent when you're covering the whole entire back wall. It was 3 burns and the guy was back in sinus rhythm. And without doing that, it would not have been possible. So I think it's really important to involve your EPs in this and really push to try to get back, have them take them back to the lab to do a touch-up ablation if you have any failures. especially late failures.
Yeah, I've got one for Dr. O'Keefe. You know, what would you say for the fellows that are training currently? What advice would you give them, knowing what you know now, so that maybe they can get a little ahead of the curve and perhaps be better prepared when they graduate?
I think that's a great question. First of all, I would encourage every fellow to go to one of the aftercare maze courses that are available, and to get as much experience, double scrub, triple scrub, stand down the table for any time that a maze procedure is being done at your institution, even if you're not going to be the primary operator, to be able to get as much exposure and comfort with the anatomy. But at the end of the day, there may not be that many cases that are done where you're going to be confident and comfortable. So I think be a safe surgeon otherwise, and then find a practice where they're able to mentor you in this aspect of your practice.
Can I ask a question, Dr. O'Keefe? Do you think that if we make atrial fibrillation treatment a quality measure, just like the IMA, in other words, if the SDS or other societies measure how we treat these patients, do you think that it would be the adoption of treating atrial fibrillation would be much increased?
I think it would be. I think if there's that expectation as a society that we treat patients with AFib, I think you'll see more adaptation of it. But I think the other thing that's important is that we have the same language and we standardize what we're doing as surgeons, because what one of us calls a maze may not be a maze to someone else. And so standardizing that lesion set, that's really important. And that was critical and key in our group, so that our cardiologists know whatever surgeon is operating on that patient, they're going to get the same lesion set and hopefully the same quality.
I think that's very important to emphasize, that is standardization of lesion sets, so that a maze is a maze is a maze, whereas we all know that a maze is not necessarily a maze in everyone else's eyes. So in our group, no one, no matter how little AFib they get, just gets a PVI and a clip. We all feel that's substandard, and that at least everyone gets a left-sided box lesion with pulmonary veins and a left atrial appendage line, as well as a right-sided lesion. In all cases, even for paroxysmal or new onset atrial fibrillation, for patients that even, for example, come in with acute coronary syndrome or non-STEMI and have an episode of atrial fibrillation not previously diagnosed, they will even get a full left-sided maze and right-sided lesions as well. So I think it's really important to standardize lesion sets, because without doing that, it's kind of a perpetual cycle that if you don't do an operation, you're not going to have good results. You're not going to have good results. The cardiologists aren't going to think it works, and then it's a downward spiral. So in our program, it is very important that lesion sets are standard, and we all think that the more you ablate, the more lesions you do, the better results you get. So we do have a set protocol for this specifically, and specifically for this reason. We look at our patients, our maze patients, more like our aneurysm patients that need longer term follow-up, and not just like a regular coronary bypass patient where we turn over everything to the cardiologist for medical management after a month or 6 weeks or so. So our current protocol is that the patients are seen in a normal two post-operative visits, which occur at 7 to 10 days post-operatively, and then an additional 3 weeks after that. At 3 months post-procedure, we use a 2-week monitoring patch. Our particular preference is using the Zeo patch because we think it's easy. There are plenty of things on the market to use. So patients then have wear that for 10 to 14 days. It gets read by our EP cardiologists, and then it gets seen back in our office at 4 months post-procedure. So then we have a conversation with them, what we call a shared decision conversation with them about anticoagulation. And they also get an EP referral, even if they have a primary cardiologist that's not an EP. And then we repeat the Zeo patch again at 1 year. And depending upon the results, we'll send them back for additional cardioversions, additional ablations, medical therapy, and do have EPs involved within 3 months of their maze procedure.
Yeah, I agree, and I applaud you for following these patients for more than 30 days. I think collaboration with your EPs is key to success, because I think that if you just follow these patients for just a month or a few months, it's probably not good enough because, as we know, many of these patients would need additional treatment, sometimes by EP. So it's really great work, and I think all programs should adopt this collaborative approach with EPs.
Dr. Philpott, I have a question for you. Excellent, really phenomenal data. Where do you think your fallouts are coming in terms of the group that you're treating? Are they the longstanding persistent patients? Is there any sense of who's not being treated and how you could kind of attack that group?
Boy, it is surgeon specific right now. And we've got a couple of longer career surgeons who never really liked the maze, and they just don't want, they were hesitant to get on that bandwagon. We've got one of our most senior surgeons who was able to pick it up overnight and has some of the best results that we have. Now, the data is that there appears to be no significant increased risk with a maze procedure, but that's also with a experienced surgeon. I think a new surgeon coming out, you know, we can tell them that the risks are the same, but in their own mind, they don't completely believe that, and I think they're actually correct. You know, anytime a young surgeon is going to grab any procedure, no matter what it is, there's going to be a little bit of a learning curve there. So what we're trying to do is to mentor our young surgeons on how to get this done. Very much like what you went through, I think that is an enviable experience that you had, and one that most groups need to really set up. They need to identify a couple of the people that are really good at it and have the young surgeon scrub with them until they're comfortable with it. And the other way around is let them do the case and then have the senior surgeon come in and stand across the table from them and just give them pointers as they go through it so it flows smoothly. I mean, really, a lot of it has to do with the sequencing, how you set it up. And I personally, for me, once I got that sequencing really down and tailored for each case, I thought the procedures went a whole lot quicker and smoother and more efficient.
So actually, I have two questions. So I was very impressed with your surgeon data and the differences between surgeons. We have not looked at our data, but we tended to standardize from the outset. What is your way to, specifically on the surgeon that had much less efficacy, what is your method to bring him up or her up to the equivalent to the rest of the group? That's question one. I'll let you answer that.
The first thing is just to have the conversation, right? Like, you know, you don't want it to just be 1 or 2 months. They've got to show a little bit of a trend there. But if they continue to show the trend, that's where you sit down with them and say, okay, if they don't come to you first, most of them will come to you and say, wait a minute, why is my number not? And that's great. But if they don't, then you need to go to them and say, we need to talk about your technique. It's just, you know, let's go through it. Let's begin to have that dialogue.
Another question I have for you is your maintenance of your left atrial appendage clip. So, you know, as I assume the rest of the group believes, as I do, these things don't move. So that when you have a bad appendage clip, has nothing to do with the clip. It's how it was placed. So, do you check everyone with the CT, even though they've had an intraoperative TE that shows adequate closure?
We do.
And the second is, what is your criteria for adequate closure by CT scan at 3 months down the road?
So the little bit of the troubling part about the TE is it's operator dependent. And the CT scans, the flash CT scans, take that whole part about did it move or not completely off the table. So, you know, we do that down the road where if there could have been any movement, it would have already occurred. And it's interesting to see the data on the clip is fantastic. Now, the CT scan protocol is specific for the appendage and not just with the clip, it's also there for the watchman. And having that standardization in place really takes out the error that you may get from provider to provider with TE.
So what is considered, Dr. Philpott, what is considered a failure of placing the clip? Meaning, do you have a specific a way, meaning if you have a pouch of less than 1 centimeter, that's considered success. If it's over 1 centimeter, it's a failure?
We've gone by what the advanced imaging physicians are calling for that. And yeah, it's actually under that. If there's any residual pouch at all, they're calling that failure. So it's sub 1 centimeter. And when you see the scans, it's actually, I have found it to be very powerful for the referring doctors. The clip tends to exclude the appendage very flush. So it's almost a smooth taper. Whereas if with the staples, you know, the failures that we've had, when you look at them, they're a bit concerning. I mean, you really want to get these people off drugs, and there is data out there to suggest that leaving a pouch may be more dangerous than not doing anything at all to it. So, you know, so the picture says 1,000 words, so to speak.
Is there a specific topic that anybody wants to review or talk about, or any questions?
So I have a question about, I saw your last table that showed the bottom one about any atrial fibrillation that they recommend with the point system for left atrial appendage exclusion and management. Is there anything that you do in terms of standardization of lesion sets, what people define as a maze, and success rates that you follow as well?
Yes. So essentially, we, because it is very difficult, I think, to impose surgeons to do specific things for various reasons. Initially, what we thought we do is we see what, you know, what everybody will do, knowing what is the standard of care. So what I can tell you is that what we've seen is the majority of surgeons will do a box lesion for cases that do not require opening the left atrium. At the same time, I can tell you that we see cases that, you know, do not require opening the left atrium. The left atrium get a full biatrial maze, depending on, you know, how old is the patient, what are the symptoms, etc. I'm not 100% certain that it's, you know, that every patient needs to get the same treatment. You know, for example, and we can discuss this, if you have an 80-year-old patient who had atrial fibrillation for the last 30 years and a left atrium that is more than 6.5 centimeters, I am not sure that I would treat this patient with more than just a left atrial appendage exclusion with a left atrial appendage clip. I don't think that in a patient such as this, that, you know, taking the extra 30 or 45 minutes to do a full maze would add anything. But, you know, I would like to hear your views on that. A question that I have for pretty much everybody: have you instituted specific guidelines to try to capture atrial fibrillation diagnosis in the patients that you see who do not necessarily come and tell you, I have atrial fibrillation? For example, we have noticed that by putting smart phrases as part of the history and physical, meaning you can't complete the history and physical unless you ask the question, well, do you have palpitations? Do you feel tired, sleepy, etc.? There's a whole slew of questions. And we have seen that we have captured patients that we never ordinarily we would know that they had history of AFib if we did not have these specific questions. Have you instituted programs to increase essentially the chance of getting that diagnosis of atrial fibrillation so you can treat during surgery?
Yeah, I can answer that. For our program, our APPs are really good about asking those kind of questions and digging through the charts. Obviously, we look at any EKGs. The other thing I started doing is looking at the stress test, because sometimes patients, while they're being stressed, will have an episode of AFib, and that may have been their only episode, and that will be enough for me to offer them a maze procedure.
Right.